Okay, so this is chapter 17, part 2, because my computer started to spaz out and freeze. We were on patient assessment in the Glasgow Coma Scale. So remember, you guys need to work on your Glasgow Coma Scale and remembering it. It's eyes, verbal, motor. So 4, 5, 6 points. 15 is a perfect score. 3, they get 3 points just for showing up. So dead body gets 3 or rock gets 3. When you guys are looking at the best motor response for Glasgow, especially with ultra mental status, make sure you're paying attention to the posturing. Did core to get posturing? They're pulling their arms in towards their core. We think about it like holding on to life. The cerebrate posturing, that's letting go of life. Both of those indicate severe neurological dysfunction. It could be temporary, or it could be something that is going to need rapid intervention to fix. All right. So when we take a patient with altered mental status to the hospital, or we suspect a stroke, make sure you alert the hospital ahead of time. With a stroke, make sure you get an onset time, the last time that that person was seen behaving or acting normally. So if they wake up with symptoms that morning, that would make the night before the last time that somebody was seen acting normally. And don't give them a vague time like 20 minutes ago. Make sure that when you check with the patient's family members, if they're there, that you say, okay, it's 4:47 p.m. right now. Well, when was the last time you saw this person acting normally? If you find that person like there, obviously we don't have onset time if you don't have anybody around that can tell you anything. There's not family members or bystanders around. But notify the stroke centers. Make sure you're taking them to a stroke center. That's an important thing. Not every hospital is capable or stroke capable. They'd have to ship them out. Some of the smaller hospitals, they'll stabilize them and then they'll ship them out. But just remember, just like with the heart, time is muscle tissue. So when you have a patient who is, not necessarily muscle tissue, time is tissue. So with the heart, it's time is muscle tissue. With the brain, time is tissue. So every moment is time that that brain tissue is becoming more and more ischemic, more and more damaged. All right, so with the seizures, it's their seizure, let them have it. So protect them from harm the best you can. You want to make sure that their head's not hitting the ground, clear obstacles from them. Try and keep the airway as clear as possible, but you don't want to stick anything all the way in their mouth, especially if they're clamping down or biting their teeth really hard. A lot of times they clamp down. We can get a suction catheter sometimes between the gum and the teeth, but when they're moving their teeth back and forth and you stick something in their mouth, and we used to put bite blocks in. We don't do that anymore because they'll bust teeth off. Your teeth have a natural alignment to them. You put something that doesn't have the alignment and the teeth are going to break. Oxygenation, even if it's blow-by oxygen while they're having the seizure themselves, that's better than nothing. Don't try and restrain a patient that's having a seizure. You're going to end up getting hurt as well as possibly hurting them. Make sure, though, that when they're in the postictal period, you want to put them in the recovery position. That's going to be the best position for them to get oxygenation and to help reduce the aspiration effects if they vomit. All right, emergency medical care again for headaches. You got to get how that headache started to present. Was it a slow onset, a rapid onset? Does it have an origin in their head? Is it in the neck? Just remember that headaches can be a symptom of other things going on with the brain. And not all headaches are benign in nature. Migraine is a diagnosis. It is not somebody with a symptom, right? So migraine it's an actual diagnosis. You can't say I'm having a migraine, and people sometimes say that as if it's a symptom of a headache. With with headaches, low flow oxygen sometimes helps relieve the pain of the headache as well. More stroke care, again, making sure that you keep their oxygen saturation above 94%. That's National Registry standard. Making sure that you are trying to keep their airway open, their tidal volume is maintained. This talks about oxygen therapy is not recommended unless they're experiencing respiratory distress or signs of hypoxia. Oxygenation. They're basically, I think the geriatric population, they worry about us if they're running on hypoxic drive. But make sure you're monitoring your patient is the best thing we can do, and provide symptomatic care and get them to the appropriate facility while notifying that facility. They have this stuff called thrombolytic therapy. It's like roto-rooter for your arteries. So there's a time frame, and they're always stretching that time frame. Per your textbook, it's 3 to 6 hours. It totally depends on the facility, the doctors, and everything else. But it is like a super roto-rooter. It goes in and it's a clot buster. It breaks apart the clots that are in the arteries. Problem is it breaks apart not just the ones in the brain, but throughout the entire body. And if they have one clot, there's a good chance they probably have other clots as well. So the patient really needs to be monitored for a longer period of time while they're on thrombolytic therapy. They have to go through a CT scan first to rule out that it is not a hemorrhagic stroke, because if they give them thrombolytic therapy and it's hemorrhagic stroke, they can bleed out very quickly into their brain. Ultramental care, our ultramental status is just supportive care for our patient. If they're in the postictal state or not, we go ahead and let them have their seizure. If they're in postictal state, we monitor them. Doesn't mean we can't load them up on the gurney, all right? Just make sure that you're monitoring them, you're providing protection for their airway, and that you're getting as best description from bystanders as you can for how their seizure presented. Somebody asked me once, well, what if there are no bystanders around? My question then is, who called 911? Very rarely we'll have a seizure patient that knows that they're about to have a seizure. They have a history of seizures and they'll dial 911 before we get there or before they have the seizure. But that's a very, very rare incident. Most times it's because somebody witnesses the seizure and then they call us. Look for clues around, look for indications, medical alert IDs, bracelets, things like that. All right, so because that was a short end to this little, we'll stop the screen share, because that was just the last few slides because my recording cut off. I want to talk to you guys about your medical assessments again. Make sure that with your medical assessment, you understand that a general impression is what you see, sick, not sick, when we walk in. All right, we don't have a whole lot of other information. We just find that patient and it's that determination, sick, not sick. It just takes us about 90 seconds to determine that, if not less. Then we go to the chief complaint. That's what the patient says is wrong, right? And then life threats. Sometimes the chief complaint and life threats can be the same thing, but sometimes as a provider, you can have a chief complaint from the patient, but your clinical knowledge says, okay, the life threats could be this, right? So if they're complaining of chest pain, but they're having shortness of breath, the immediate life threat could be the shortness of breath. We have to fix that, right? The chest pain's still a complaint though. And then we go through our primary assessment, determining if they're a priority patient. Remember, you determine that all the way up from the general impression, which is your first step in your primary assessment. So general impression, if you have a poor general impression, if they have an altered level of consciousness, if you're having to work to do anything with their A, B, C's, D's, and E's, airway, breathing, circulation, anything that can cause long-term disability like a stroke, or if there's an environmental exposure or hazard, those are priority patients. So we already know before we even get to that last step where we're determining their priority. In the back of our head, we already know that. We're still maintaining though and completing our primary assessment. And then, so we have general impression, chief complaint, life threats, we do our primary assessment. We do our secondary assessment based on the symptoms with medical patients, okay? You need to assess 5 things for the points on your skill sheet. I'm telling you that you need to assess proper things, all right? So for neurological, we're going to check our CMS. We're going to do a Cincinnati stroke scale. We always are getting a blood sugar for altered mental status. That's early on. We always check the cardiovascular and the respiratory system together. Remember that the same mechanisms that can cause a clot in the brain will cause a clot in the heart. So it's the same risk factors. Integumentary is the skin. It's very, very easy to do a skin assessment on a patient, and it takes absolutely no time. So once we finish that and we get all the clues from our secondary assessment, we're narrowing it down and we come up with our field impression. Our field impression is what we're doing as clinical providers, the decision we're making in a pathway or an algorithm to go on to treat our patient. So through your secondary assessment, you're including or excluding things from what's going on, right? You're doing it rather quickly, but the little bubble over your head says, well, this altered mental status could be blood sugar. It could be they've had a seizure and they're postictal. It could be because they have a head injury. It could be because they're having a stroke. So they could have agitated delirium or delirium. While we're doing our assessment, we're including or excluding things. We're either popping the little bubbles over our head because they're not pertinent anymore, all right, or we're keeping them there. When we get down to our field impression, we think about what's left of all the things that we've assessed and we've either popped the bubbles or we have left over our head. And this is how I do it. The most severe of those that we're going to go off of that pathway, I treat worst case scenario backwards. So what's going to kill them now? What can we fix right now with our primary assessment? And then what pathway should we follow for this? If somebody's having a TIA, we're treating it the same way as a stroke because we really don't know the difference, okay? We can't state the difference. We're not in that long-term setting. They could have symptoms that come and go over time, and that's where they're reporting it. It's maybe these are reoccurring again, but that TIA is progressive, all right? If they're having a seizure, again, we as EMTs can only provide supportive care for those seizures, okay? Toxicological emergencies, we're looking for clues on the scene, all right, to something they might have overdosed on or been exposed to, drug overdoses, medication misuse. We're finding all that information with our secondary assessment. And then we determine our field impression, and then at the bottom of that, we treat our patient, okay? And then during our reassessment, we always start at our primary assessment and go back down. Every intervention we made, from putting our patient on oxygen to making sure that they have adequate tidal volume, those are interventions that have to be reassessed with our reassessment when we go back down. So it's a big process, but if you start like an upside down triangle and you start with the big picture, right, and then you get more information, you narrow down the parameters, you're able to make your field impression and then treat your patient. So I was going to play a video for you, but it's not seeming to load. So that's the end of chapter 17. I'll load this up in there. Remember to come to class with questions for the Q&A sessions. Do your quizzes. Make sure that you're grasping the material on the quizzes. Ask questions appropriately.